Welcome from my side as well. Dear colleagues, dear friends, this year we have again a great keynote speaker. Professor Lenny Verkooijen is a medical doctor and clinical epidemiologist from Utrecht University. She is professor of evaluation of image-guided therapy and head of the local research office. Lenny has a very strong interest in combining clinical research with clinical care, and she is one of the worldwide leaders in exploring how to use cohorts to clinical trials in an approach that is called TWICS, Trials Within Cohorts. And she has several very exciting projects, very successful in Utrecht, and I'm very sure that with the fantastic cohorts we have here in Basel, we can learn a lot from her research, and she will introduce it in the next couple of minutes. So please welcome Professor Lenny Verkooijen. Lenny, the screen is yours.
Thank you very much, Lars. Good afternoon, good morning, everyone. My day is already quite long. I'm in Saalbach on a ski holiday, which is the main reason that I'm not in Basel today, unfortunately. But it's a pleasure and an honor to have the opportunity to give this keynote lecture here today. I'm going to see, I see my first slide. Yes, as Lars already mentioned, I am a medical doctor by training, a clinical epidemiologist, and very intrigued by evaluation of innovations. And in oncology, there's a lot of innovation going on. This is a few examples from my division, the Division of Imaging and Oncology in the UMC Utrecht. And we have all kinds of new treatments, CAR T therapies, we have the theranostics, the nucleide therapies, we have the MR-Linac, the MR-guided radiotherapy treatments, we have all kinds of futuristic surgery operating rooms. And the idea is that all those new treatments are very precise, very tumor targeted, very much aiming to only target the tumor and leaving the healthy tissue around the tumor without damage. And the idea is if you are so precise treating patients, then you will get better tumor control and less toxicity to healthy tissues, so better survival and better quality of life. And in theory, that is, of course, a very plausible idea. But my main passion in my work is to show that all those theoretical benefits of these beautiful innovations translate into real benefits for patients. And the best way still to do this is to run a randomized controlled trial. But many of my colleagues, clinical colleagues, people who have actually been inventing these kind of innovations, they say either, well, it's too complicated to run a trial. It's not necessary to run a trial because this treatment is so effective. It's impossible to run a trial because they have all kinds of reasons. And I agree with them that it is not easy to run a trial. I'm going to see whether this works. Or how do I? No, I have to do it differently. Sorry. Yes. For all of you who have been involved in running classic RCTs, they know that it is a challenge. It takes a long time to translate a fantastic research idea into a financially approved and ethically approved research protocol for a trial. On average, in oncology, it takes about 2 to 3 years. Another issue when you run classic RCTs is that of generalizability. People ending up in trials are usually the ones that are relatively healthy, that are younger, that have less comorbidity or only little comorbidity, that have a higher level of education. But the treatments that you are investigating in trials are treatments, in my case, that are meant to the entire cancer population. And that's a very heterogeneous population. That is in general an older population, and people have a lot of comorbidities. Another challenge in the classic RCT is that of disappointment bias. If you have a patient with cancer and you tell this patient about a new treatment that is more precise, high-tech, probably better than the old treatment, because that's why you're running this trial, And then the patient has to undergo the randomization. And when they end up in the control arm, you see a lot of disappointment with the patients, but also sometimes with the doctors. They find it difficult to tell the patients, well, sorry, you can't get a new treatment. We will treat you in the standard way. The procedure of informing patients about a randomized control trial is also quite confusing for patients, because at a very difficult time during their treatments, they have to talk with their doctor about the treatment options, prognosis, but then all of a sudden the doctor also has to explain the trial and the new treatment that is being trialed in this study, and the doctor has to explain the concept of randomization and what happens if you are randomized to one arm or the other arm. It's very confusing, very time-consuming, and for many doctors a reason not to invite patients to participate in trials, and for many patients to say, well, it's all too complicated, it's too much right now, I don't want to participate in this trial. About 40% of trials is stopped prematurely. That has mainly to do with slow recruitments. Recruitment rates are usually overestimated before the trial starts, and many trials do not manage to recruit enough patients in time. And then in oncology, what we also see is that for a similar condition, there are more and more innovative treatments. For example, for early breast cancer, we have now about 6 treatments to remove the primary tumor. And ideally, you would trial all these new treatments against the standard of care. But with so many treatments, and that even for breast cancer, where we have a lot of patients, the amount of patients would simply not be enough to run all these separate trials. So we have to find another solution. And some will say, well, fortunately, now we have big data, machine learning, deep learning. And when we make efficient use of all the routine data and the big data that we have in our hospital information systems, in other kind of databases in different countries, we can estimate the effect of all these new treatments, and we don't need to run randomized controlled trials anymore. Well, the problem is that there is something about randomization that can never be mimicked by real-world evidence, because it's with randomization that randomization is the only way to get rid of the selection by indication bias. When you are going to look in the real world what the effect of a new treatment is, an innovative treatment is, compared to standard treatments, you will have a bias, because patients who are undergoing new innovative treatments in routine care are inherently incomparable to patients who receive standard care. And you can try to adjust for all the factors you can measure. You can adjust for age, socioeconomic status, comorbidities, but it is simply impossible to adjust for all the factors, all the confounders, and there will always be a certain extent of residual confounding, and you don't really know in what direction that goes. So the conclusion of this paper, I think, is very worth reading in the New England Journal in 2020. They say that the replacement of randomized trials with non-randomized observational analysis is a false solution to the serious problem of ensuring that patients receive treatments that are both safe and effective. So real-world evidence, real-world data, big data, they are very useful, but if you really want to look at effectiveness of new treatments, you need to have some form of randomization. And that's where we thought, well, maybe we can combine the best of both worlds. And we do that with our TWICS approach, the trials within cohorts design. So I'm going to take a couple of slides to explain you this design. So here we have a cohort, or maybe a registry, or even routine care, a group of patients with a certain condition. And these patients are then identified as a cohort. And from these patients, you take all kinds of measurements, baseline measurements, maybe some outcome measurements. You have imaging data, all the data that are generated in routine care, the regular measurements, regular outcome measurements. And those data can come from different sources. They can come from the hospital information system. They can come from cancer registries. They can come from statistics, national statistics, and they also can come from patients themselves. You can ask patients to tell you by means of standardized questionnaires what their quality of life is, their physical functioning, and their workability. So far, it's a standard cohort. But then the next step is to see, okay, let's see within this cohort which patients would be eligible to enter a trial. Which patients in my cohort meet the in- and exclusion criteria? And you see these patients here in red and blue. Those are patients with a certain condition who are in a cohort and who meet in- and exclusion criteria of a certain trial. These patients are then randomized. The blue patients, they are randomized to the control arm and they receive standard of care. And the red patients, they are randomized to the intervention arm and they are approached by a researcher and they are offered to undergo a new intervention, a new treatment, an experimental intervention. And the patient at that point in time decides whether or not he or she wants to receive that specific treatment. And since you have been collecting baseline data and follow-up data for both groups at the same time points in the same fashion, you can compare their outcomes, of course, of this red group with the blue group in an intention to treat analysis. So this is the concept that we wanted to implement in our clinic. I think it's already almost 10 years ago, 2012, when we first thought that this would be a good idea to make evaluation of all the innovations that we are developing in our hospital and in our country to do that in a more efficient way. So that's where we set up the innovation clinic. And this is an approach where we say, okay, instead of running trials and finding patients to enter those trials, we turn it around. We set up an innovation clinic where we set up a structure where that allows us to learn from every patient. So every new patient with cancer that come to our hospital, they see doctors, they see nurses, but they also see a researcher or a research assistant. And they take 20 minutes to inform patients about the importance of clinical research. And they also inform patients about data privacy issues. And when patients understand and are open to continuing this conversation, and practically all patients are, we ask informed consent on several levels. First of all, we explicitly ask patients, is it okay for you if we use your clinical data that are generated during the treatment of this tumor within the hospital, but also maybe in other hospitals? Can we use those data for research purposes? Some patients, we also ask them whether we can biobank blood or tissue. We also ask patients to tell us how they are doing 3 months, 6 months, but also 1 year, 5 years, and even 10 years after their cancer treatments. We ask permission to take extra scans, and then patients decide which informed consent they want to, which type of informed consent they want to consent to. And the final informed consent we take is the broad consent for randomization. And that works as follows. Because when a patient comes into our clinic with a certain condition and we want to enroll this patient in a cohort, we inform the patient about the cohort and we take informed consent for data collection. Can we use your data for research purposes, and do you want to fill out patient-reported questionnaires, etc. When patients say no, fair enough, we identify the patients as such in their hospital information records, so they cannot participate in the study, and that's okay, but we see that very few patients say no at this point in time. Most patients say, of course, you can use my data for research purposes. So if they say yes, then we ask broad consent for randomization. And here we tell them that it may be possible that in the near future or in the not so near future, let's say 10 minutes from now or maybe 5 years from now, they may be randomized. And that will mean that they may be randomized to an intervention arm, in which case they will be offered an experimental intervention. But they are also informed about the fact that they may be randomized to a control arm. And then we tell them, if you are randomized to a control arm, you will serve as a control, but we will not inform you about that. You will not be informed about the fact that you are a control in a trial. So here at this point, patients have the opportunity to say, no, I don't want that. Those patients can participate in the cohort studies, but they cannot participate in the randomized controlled trials. But patients who say yes, they may enter the first stage. They also may not enter the first stage, but when they become eligible for a trial within the cohort, when they meet the in- and exclusion criteria, those patients are randomized. When they are randomized to the intervention arm, we approach them again. We explain them about the experimental intervention. We also explain them about the standard intervention, and they decide whether or not they want to undergo this experimental intervention. When patients are randomized to the control arm, as I already said, they will serve as a control. They are not informed about this specific intervention. They do not receive an explanation of a treatment that they will not be able to undergo, but they will serve as a control. In Utrecht, we have been doing this for quite some time now, as I already said. The first ethical procedure, the procedure with the Medical Ethical Review Committee took quite some time. It took about a year. It was also taken up to a national level to see, okay, how do we approach this issue of trials within cohorts? How do we approach the issue of patients being control without really knowing that they are a control in this specific trial? So we thought things through. We had very useful discussion, and then after the first TWIX infrastructure was approved, then it became a lot easier. So now we have several very large cohorts. We have 4,000 breast cancer patients. We have a national cohort of patients with colorectal cancer. We have also a cohort of patients with metastasized disease to the bones, bone metastases, well, lymph nodes, brain mets. Prostate cancer is a relative recently started cohort. It's also growing very rapidly. And as you can see in the right column is that the majority, and sometimes in many cases the far majority of patients can give broad consent for randomization. And that means that with practically all patients we approach giving approval for participation in the cohort, 95%. And then of that proportion, 82% consenting to broad randomization, giving broad consent for randomization. That means that in theory, about 70%, more than 70% of all eligible patients can be randomized into trials. So we have now been doing this for quite some time. We have completed 4 trials. I'm showing you this slide to show you that these trials are there are 2 radiotherapy trials combined with surgery in rectal cancer patients, patients with bone metastases. We have a surgical trial, and we also have an exercise trial in breast cancer patients. And we managed to publish them in very reasonable journals, especially the radiotherapy trials. They were published in the Red Journal. So that I show you this to tell you that it's also more and more accepted by in this case American journals. The next slide shows you some trials that are still ongoing. We also look at a trial on the impact of measuring circulating tumor DNA and treating patients accordingly. And we also look at hyperbaric oxygen therapy in patients who have late radiation toxicity after breast cancer treatment. Those trials are still ongoing, and there are some new trials in the pipeline. What I want to do right now is to discuss 3 of those trials with you. This is the first one, the rectal boost trial, and the rationale for this trial is that in patients with locally advanced rectal cancer in the Netherlands, they receive neoadjuvant chemoradiotherapy. So in the upper 2 panels, you see the tumor before treatment. It's a rather large tumor that was treated with chemotherapy and radiotherapy. And in some cases, as you see in the lower 2 panels, the tumor completely disappears. So there's no imaging evidence and no evidence on on visualization of presence of a tumor. And in those patients, more and more, we can choose for either a watch and wait approach, where we follow the patient rather intensively and only operate when we see regrowth of the tumor, or we have a very organ-sparing treatment approach. And the question we wanted to answer is, okay, can we improve the proportion of patients that has a complete pathological response after neoadjuvant chemotherapy, and thereby improve the proportion of patients in which we can spare surgery? So this is a trial. This is in the right upper corner, the PhD students who have been working on this trial, and also the queen of the organ sparing, the watch and wait policy, Angelita Haber-Gama. She was the one who first conceptualized this approach of watch and wait. But what we did, we looked within our colorectal cancer cohort in two participating centers, the Universität Utrecht and the Maastro hospitals, and we looked which patients with colorectal cancer met the inclusion criteria. And those were patients with locally advanced rectal cancer that were participants of the cohort and that brought informed consent for randomization. From this group of eligible patients, we randomly selected a group of people who were offered to undergo dose escalation. So they received a higher 15 Gray higher dose to the tumor. And this group, the dose-escalated neoadjuvant chemoradiation versus the standard neoadjuvant chemoradiation, were then followed in the context of the cohort, and we looked at pathological complete response, tumor regression, and quality of life. This is a trial where we included in total 128 patients, and we saw, here you see the outcomes. We completed this trial within almost 3 years, so that was quite a reasonable time frame. We also saw that of all the patients that could have been randomized, 65% was actually randomized. So we have we think quite a high representativeness level in this trial. And unfortunately, we didn't see an effect on the primary endpoint. There was no difference in pathological complete response rate. 36% in the boost in the intervention arm, 37% in the control arm. But we did see more tumor regression in the boost arm. Patients, almost 70% of patients had very little tumor left and could have been candidates for organ-sparing treatment. And that was only the case in 45% of patients in the control arm. And that difference was significant. On the other hand, what we also saw that the quality of life of patients in the intervention arm, you see the two lower curves, the red are the people in the intervention arm, the boost-treated people, and the blue lines are the patients that received the control treatments. And you see that the quality of life, physical functioning and social functioning deteriorated more strongly in patients undergoing dose escalation therapy than in patients who received standard treatments. After 24 months, the quality of life in these domains was more or less the same. But it was, the conclusion of this trial was, the primary endpoint, there's no effect of pathological complete response and a deterioration of quality of life. Another trial that I would like to present is that of patients with painful bone metastases. So a large proportion of patients with advanced cancer develops bone metastases at some point during their treatment and follow-up. And those are painful. And a good way to treat painful bone metastases is radiotherapy. And what we usually do is that we give 1 × 8 Gray to the tumor. Sometimes you divide the dose in more fractions, but with 1 × 8 Gray, so it's one treatment, it's relatively short, it's relatively simple, and you get a response, a pain response, in about 60 to 70% of patients. So there is room for improvements. And the question was, well, when you use stereotactic radiotherapy, you can be much more precise. It allows you to spare the healthy tissue around the tumor, and it allows you to give a higher dose to the tumor and thereby maybe a better pain response. So, but this treatment is more complicated. Patients need to undergo pre-radiotherapy MRIs. There's this whole workup. It is delivered in several fractions, and it is more expensive. So the question was, can we achieve better pain response in patients with painful bone metastases when we use stereotactic body radiotherapy compared to standard radiotherapy? This was the vertical trial. Here are the 2 PhD students who have been working on this trial. And within the present cohort, it's a cohort of patients with painful bone metastases. We identified patients who met the in- and exclusion criteria for the vertical trial. And of this subgroup of patients with meeting this in- and exclusion criteria, we randomly selected a group who was offered then stereotactic body radiotherapy. And we followed those patients in the context of the cohort study, and we compared the pain response of these patients treated with and without stereotactic radiotherapy during the first 3 months following treatments. Well, we saw something very interesting happening. It was a trial, it was a phase 2 trial. So we randomized in total 110 patients, 55 in each arm. What we saw in this trial, and we see that more often in palliative trials, is that we have quite some dropout in both arms shortly after randomization. And then we offered stereotactic body radiotherapy to 45 patients. But interestingly enough, we saw that 1 in 4 patients, or more or less, refused to undergo stereotactic body radiotherapy. They said, well, it's such a hassle. I have to come back to the hospital several times. It's too much for me. And the alternative treatment, the standard treatment, the 1 × 8 gray treatment is much easier, it's much faster. So I really want to undergo the standard treatment, and I refuse to undergo the experimental intervention. So of the patients who accepted stereotactic body radiotherapy, there was 7 of the 33 who were unable to complete the whole treatment course because it was too burdensome or the disease progressed. So that's also something we saw. So finally, of the 55 patients randomized to the intervention arm, only 26 were able to undergo the complete treatment. In the control arm, 44 of the patients really underwent the control intervention. And I think, of course, this is on one hand annoying when this happens in a trial, but for us it was also very informative because it tells you so much about this treatment. It tells you something about the acceptability of patients, and it also tells you something about the feasibility of patients. Are patients able to tolerate this treatment? So this is a spider plot of the proportion of patients who reported partial or complete pain response at several time points, at 2 weeks, 4 weeks, 6 weeks, 8 weeks, and 12 weeks. And as you can see, the 2 surfaces, the red surface is patients with stereotactic body radiotherapy. The blue surface is control patients. And as you see, there is not much difference between the 2 groups. The 2 surfaces practically overlap. And we see at the different time points, response rates between 40 and 60%. And those differences were not significant. The final trial I would like to present is the SPONGE trial, and that is a trial that we performed also in the colorectal cancer cohort. Patients with tumors in the lower abdomen, when they undergo surgery, they are often put in a Trendelenburg position, because that way the small bowels are replaced a little bit out of the operation field, and it's easier for the surgeon to operate. But this Trendelenburg position also has some downsides. It's patients after this procedure, a rather long procedure in this position, they complain about headaches, they complain about, they may develop pulmonary or cardiac problems, and that may prolong their hospitalization. So there was this sponge that instead of putting patient in a Trendelenburg position, you keep the patient completely horizontally, you enter a sponge laparoscopically, and this sponge enlarges within the abdomen and keeps the small bowel out of your operating field. So you can leave the patient horizontally and you still have clear operation fields. There were quite a few surgeons who were already using this sponge, so we said, well, let's trial and see whether it really leads to benefits for patients. So in this, this was also a one-center trial, single-center trial. Patients who were eligible for a sponge intervention, those were patients with tumors in the lower abdomen that would need to undergo surgery in Trendelenburg position. They were randomized, and the intervention arm was offered sponge-assisted surgery. And in this case, everyone said yes. No, there was no one who refused to undergo a sponge intervention. And people who were not randomized to the intervention arm, they received surgery in Trendelenburg position. And those patients were followed, both groups, for duration of hospitalization and 30 days complication, because the idea was that when you prevent to put patient in the Trendelenburg position, you will have less cardiac and pulmonary complications. So here you see the outcomes. There was no difference, no significant difference in terms of postoperative stay, 5 days for patients in the sponge arm and 4 days for patients in the Trendelenburg arm. No difference in terms of 30 days complications, and no differences in readmission or 30 days mortality. So also here a negative trial. Well, the surgeon who really likes to, the surgeons who like to use the sponge, say, well, it's not very expensive, and I like it's for me it's a lot easier to operate with the patient it's in horizontal position. So that's what you always see. That's my impression. And when you have a negative trial, there's always a lot of other reasons that doctors come up with to continue to work with that innovation. But at least there's no, from a clinical perspective, there's no reason to use sponge-assisted surgery. So what do patients think about this design? Well, we did a few surveys in our patients. This is a survey that we performed in patients who were randomized to an intervention arm. 108 in total. So they were randomized in a trial and ended up in an intervention and were offered to undergo the intervention. And we asked them, do you know why you have been selected to undergo this intervention? And there you see that about half of the patients, they either don't know and don't care. And a small proportion, 5%, says, no, I don't understand why you offered me this treatment, but I would like to have known. 7% thought they were specifically selected to undergo this treatment, and only 42% understood that they were allocated by chance. This is a bit disappointing, I thought, but I have understood that this is not so different from the classic RCT. The concept of randomization is a complicated one for patients, but this is something that we have to work on, I think, as clinical researchers, to work towards better understanding among patients. This is more recent results. This is a trial. This is a survey where we approached patients who had been controls in 2 of the trials, in a rectal boost trial and in another trial that I didn't show, an exercise trial. And we told them, well, you were control in a trial without knowing this. How do you feel about that? And there we saw that the majority was actually happy that they had been contributing to clinical research. 43%, well, they didn't really care. And only 1 patient was negative. He or she, I don't know, said, well, that he would have liked to know that he was serving as a control. These numbers were a bit more disappointing when we say, what did you think? What do you think about the fact that we did not inform you about being a control? So even though patients generally liked a lot being a control, but the proportion of patients being positive about the fact that they were not informed was slightly lower. It was 26%. Those patients said, well, why would you have informed me about something that is completely not interesting for me? 67% was neutral, and there was 7% of patients who were negative. And the most important thing is, well, I completely forgot about this. You could have reminded me more regularly about the fact that this might have happened, that this could happen. So this is now something that we are working on. So how we keep our cohort participants updated about the fact that they are participants in a cohort and about the fact that they may be randomized to trials and the consequences that that entails. This is a slide I would like to share because these types of trials are, of course, randomized controlled trials, but they have some peculiarities, and those I'm very happy to have contributed also with Lars and a group of epidemiologists and clinical researchers to design the cohorts routine criteria, so a checklist for trials that are run within routine settings in cohorts and registries or electronic healthcare systems. And I think this brings me to my last slide. And I'm happy to, I thank you for your attention, and I'm happy to answer your question.
Excellent, Lenny. Great talk, and I'm sure there will be some comments or questions that are on your fantastic results, and I don't mean that only for the clinical decisions, also how you do research. Do we have questions? Online is perfect as well. Yeah, over there.
Well, thank you for this excellent presentation and the seminar work that you have done with your group in this regard. I still have some problems with the decision not to inform those patients who serve as a control. I understand it from the general view that they consent in being randomized, but why don't you inform those patients who are randomized to the control group? This, depending on the design, this may create problems in the expectations. If, for example, there is a high expectation in a new treatment approach that you want to test, and those who are not informed that they are control groups are deprived of the placebo effect. In objective outcomes, it may not be an issue, but in those where expectations on both sides may play a role, I think this introduces a significant, or might introduce a significant bias. Would you comment on that?
Yes, thank you very much for this very, very good, very relevant question. It is indeed a very pragmatic approach. So if you are interested in estimating a placebo effect and you want to do a placebo-controlled randomized controlled trial, then this is not the design, because it's impossible to give patients, according to this design, a placebo treatment. So there will always be room, of course, this is only an alternative for very pragmatic research questions. What would happen if I would introduce this new treatment in clinical practice? And indeed, in the control group, we have no placebo effect, which we also don't have in real life, in routine care. And the reason not to inform patients in the control arm is one that I think it's at the fundamentals of this design, because this way you remain very much closer to clinical practice. You don't inform patients about treatments that they will not be able to undergo, so we feel it's more patient-centered, and you avoid contamination and disappointment bias in your control arm. And I agree with you, the placebo effect that may happen in your intervention arm, that's not something that you are dealing with with this approach. That's not something that you are controlling for in this approach.
Thank you.
Yes, Matthias.
Yeah, thank you very much, Lenny, for your talk. You know, I'm very fond of Twix, but still, when you analyze these trials, and you said it is very informative that we see, okay, how feasible it also is, and how accepted a certain treatment then is. That you still have a might have a large proportion of patients who actually do not take up the offer of this new treatment. And then you still do an intention to treat analysis, I believe. So you analyze all patients in the group to which they were randomized. So did you not also do a per protocol analysis, and that your negative trials might also be become negative because you have a large proportion of patients actually not doing the intervention or taking the intervention?
Yeah, absolutely. We definitely did that. So we, of course, we do an intention to treat analysis. We do also do a per protocol analysis, and we also have the option to do the instrumental variable analysis. So a case, a causal average, an analysis where you make use of the fact that you have practically 100% compliance in your control arm, and that allows you to estimate the effect in your intervention arm to correct for your non-response in your intervention arm. So we have several ways to analyze the effect of the intervention, and we did that also in these trials. Not in the trial where we had a very high uptake of the intervention, but in the other trials we also did an instrumental variable analysis and also propensity score analysis actually. But it gave the exact same results. So also in the per protocol and the instrumental variable analysis, the results remained negative.
Yeah, good to know. Thanks.
Miriam?
Thank you very much for this excellent talk. You mentioned that in a classic randomized controlled trial, one problem is that the population is not representative because they are usually younger and less comorbidities and have a higher level of education. But don't you have the same problem here, because the patients have to consent to be randomized? So it's actually the same. Or did I misunderstand that? And did you compare with the patients that did not consent to be randomized?
Yeah, I see your point, because partly it is due to the in and exclusion criteria. So if one of the inclusion criteria is we only have an upper age of 70 years and no comorbidities, that is not something that you take care of with this design. But what we still see in randomized controlled trials is that in classic RCTs is that many patients are not even invited to be in trials. And those are the patients that are have a language barrier, patients that have so many other comorbidities that they don't even have the time or the room, or the physician don't even want to bother these patients with more information about another trial. And those are the or sometimes it's simply because the doctor is too busy and he say, okay, this patient is always talks a lot, older patient, I'm not going to bother even to talk about this trial because I don't have any time. So, but this way, by sort of disconnecting routine care from research, we invite each and every patient to our innovation clinic. So we give every patient, old, young, highly educated, low educated, comorbidity, no comorbidity, they're all invited to this innovation clinic. And there we see that about 90% who is offered to participate in the cohort, they agree to participate. And of those, 82% gives broad consent for randomization. And those are indeed we compare them in terms of tumor characteristics. They're usually people who have, we see that very young patients tend to say no, but in general, there's not a lot of difference between that in measurable baseline characteristics, but of course they are different. But still, and that's what I try to explain, is that when you have 90% of all patients want to participate in a cohort, 80% of all patients who want to participate also allowing you to randomize them, then in theory, you can have 72% of all eligible patients randomized in a trial. And that, I think, is still not 100%, so it will still be a selection, and not those 72% are different from the 28% that are not that you're not able to randomize. But it's so much better than what do we get in usual care, in usual practice? It's 5 to 10% if you do really well of all patients that could be entered in trials actually end up in trials. So even though it's not 100%, it's still better. And so, for example, for the BOOST trial, where we looked at the locally advanced rectal cancer patients, we looked within the Dutch Cancer Registry and compared the characteristics of these patients with our trial participants. And there was indeed, in terms of age, gender distribution, comorbidity, and stage distribution, they were very comparable to the cancer registry, so the population-based data.
Okay, I think we have one short last question. And
yeah, thank you very much for this excellent talk. You have the big advantage that you have a cohort, but what about acute phase trials? Do you also have experience or others with patients coming with an acute condition based for these type of trials?
Yeah, I see the point. I don't have acute patients, but sometimes we randomize within 15 minutes. So a patient comes in, we invite this patient to have a chat with a researcher, to the innovation clinic, and then we ask this broad consent for randomization, and then we tell this patient, okay, if you agree to this, if you give broad consent, you may be randomized within 5 minutes, or sometimes it will take longer. So for the rectal BOOST trial, patients came to the radiotherapy departments. Before they saw their radiation oncologist, they had this chat with the researcher. And if they gave broad consent for randomization and they met the in- and exclusion criteria, they were immediately randomized. So we had to have this conversation, of course, with the medical ethical committee, but they were immediately randomized. So that probably approaches a little bit the situation that you are describing. But I have no experience with patients who are brought in unconsciously and who need immediate treatment, where you don't even have the time to have a conversation with them. I know that John Nicol, who is one of the people who conceptualized this design, together with Claire Welton, they were both in Sheffield at that time. There are quite a few examples in acute care where the informed consent for randomization was waived because they said, well, there's no time for randomization and it is important to run this trial. So maybe in those settings, you could take maybe look at those settings to see whether you can combine those decisions with the TWIX design. But I do not have experience there. But sometimes we have this whole process of randomization in a very short time frame.
Thank you, Lenny. Thanks for showing what is possible, highlighting what kind of methodological challenges appear when we think closer about randomized real-world evidence. And I'm very happy for all your input, and I think I share that with the audience. So thank you very much, Lenny, for this great talk. And yeah, nothing to add. Thank you.
Okay, thank you. Bye-bye.